details of that, but eventually trainers will have the caliber of training people. And they have to be motivated. Motivation may be sometimes by money, sometimes by prizes and awards, but more importantly, by the change in the law of promotion. We are no longer going to be promoted in the university from assistant professor to professor or lecturer to assistant professor by producing a few papers, publishing a few papers. That's not enough. You have to serve the community, you have to train people, and you have to show that you have actually participated in the community service. And how are we going to do that? There is a structured national program today. There are training logbooks, and there are research portfolios, and everything is converted into credit points. And there is a program that is being developed already for online training follow-up by doing tests for people regularly to make sure that they are actually receiving their trainings. We now have already national Egyptian Medical Board scientific committees in internal medicine, surgery, ob-gynae, pediatrics, and family medicine. And as you can see here, the representation of the universities in these committees is quite homogeneous. Each committee is formed of 15 individuals who have been working for 1 year now. They produce the national training programs in their specialities, and these are the programs that I'm telling you will be implemented on March 1st, after 2 weeks. Programs will have to be evaluated by hard endpoints, which are reflection of the results of treatment on parameters which we are working on, and has to be enforced by law. And we are expecting the law to come out as soon as the country settles a little bit. And it's going to be a promotion requirement. So far for education, research is the second component that is the second wing that you have to fix to a clinician to become really a good clinician. Research is a diligent, systematic inquiry or study that validates and refines existing knowledge and develops new knowledge. And 3 kinds of research can be done in the clinic, can be done by practicing physicians without having to go back to the universities or research centers. They can make observational studies, interventional studies, or translational research. I'll go through examples of that very quickly just to convince you that every clinician can do research without having to be highly sophisticated. And in fact, today you can publish easily such kinds of 20, 30 years ago, you wouldn't have been able to publish in a good journal if you don't say cytokine at a certain point. But now you can just don't speak about cytokines. You can talk about a patient, about a series, about... So observational studies can start with just report an interesting case. Just sit down, sit on your desk, get a paper and pen, and write what you have found, and publish that, because this will make you acquainted with the method of publication and so on. You can collect a number of patients and lupus nephritis and examine them and tabulate them and publish a cohort. This is low-level publication, of course, but it's the start. People have to start learning something about it. And then you start to do evidence-based practice and epidemiological research. You can be indulged in registries. Professor Tarda told us that this is one of his primary interests. When there is an outbreak, it's a great opportunity for clinicians to talk about, to do some research about the outbreak. Rick Johnson just told me that he's going to talk to us about an outbreak in Nicaragua. So that is a way of alerting physicians that when you see an outbreak of something, this is a golden opportunity for you to do some work. And of course, endemic diseases should be inviting to local people to do whatever they think is appropriate. I must say that even physical examination can be a target of a systematic research. For example, this is called the STAR Statement of Reporting Diagnostic Accuracy in Studies. This is a meta-analysis that addressed many centers, and they asked people to refine the importance of a particular symptom or sign, how many are false positives, how many are false negatives. This can be applied to an individual, not necessarily to everybody. You can do it for yourself. For example, if 100 patients come to you with headache and 60 are hypertensive, then is headache a symptom of hypertension? You will soon realize that it's not. Headaches are very common, and hypertension is common, and headache cannot be taken as a sign of hypertension, symptom of hypertension. And you can refine also, for example, your ability to detect a splenic enlargement. You detected a spleen, and then you do an ultrasound, it wasn't spleen, it was the last rib. So you start to know that, in fact, your false positives about spleens are high, and you start to refine your training about detecting splenomegaly, and so on. So you can do this to yourself and know the diagnostic accuracy of your ability to hear murmurs or to feel spleens or to do these things. To develop an evidence-based practice process, you need 5 questions. Ask the question, acquire the evidence, appraise the evidence, apply to patients, and evaluate the outcomes. And I'm going to give you the example, for instance, of the rifle model. Everyone here in this room knows the rifle criteria for acute kidney injury, and as you know, it's classified into 4 stages: risk, injury, failure, loss of function, and ESRD. This is perhaps one of the most quoted diagrams in the world today, in the world of nephrology. Look at the validation. When you validate the rifle, here is one study that shows you the mortality in relation to risk in A, to injury in B, and to failure in C. And you can see here the meta-analysis of so many studies showing that the distance between the line of neutrality and the findings has been increasing progressively from A to B to C. Like you see here, the distance here is very small, becomes larger, becomes very large here, distance small, larger, and larger. So you can see that obviously the classification into R and I and F is valid because it reflects eventually on mortality. That's what I mean by validation. Epidemiological research. You also need to pose a question. You have to calculate power, expected numbers of patients, and so on, and then a statistician will tell you, even you can do it yourself without a statistician, what is the sample size expected for this study. Then you see how much money is needed to do the study, randomization, and make sure that randomization is ensured, and then define endpoints, primary and secondary endpoints, and do the analysis and publish. And perhaps the model I'm going to tell you about this was this question, which was posed in the Gringen study in the Netherlands, called the PREVENT study, related to the incidence of proteinuria in the population. The question was very simple: how much of the population, how many people got proteinuria, and whether proteinuria has got a relation to other things. And the curve that everyone of you knows shows that in fact 7% of the population in this area has proteinuria. Look at the number: 40,548 subjects included. Actually, the whole village was included in the randomization process. It wasn't a randomization, it was such an exclusive thing. And this study was an open landmark study to many other studies done all over the world, as you can see here in the United States, in South America, in Africa, in Asia, and everywhere. And I'm happy to tell you that the first Egyptian study has been published about this by Dr. Zaghloul of Damanhur and his colleagues. This was published in the Saudi Journal, showing that we have actually entered the era of looking into a national problem, the prevalence of CKD in Egypt. The limitation of this study is that the study population was only relatives of dialysis patients, so the genetic factors, environmental factors are a little bit biased here, but they came up with a figure of 21%. Interventional studies have been also conducted by clinicians. I will quote here the randomized control trials, which need a design, a registration, data collection, data analysis, primary endpoints, secondary endpoints, publication, and post-hoc analysis. The most famous study that has been known to everyone here is the DCC trial, where diabetics were compared under control and intensive control, and you can see the difference that everyone knows, that intensive control of diabetes is more beneficial to the outcomes. Translational research is the vogue today. Actually, it's very recent. The first publication using the name translational research was in 2008 in the British Medical Journal. And by translational research, I mean these four steps. That a basic discovery is made, then someone looks into the basic discovery and says, wow, why don't we use this in patients? So you go into controlled environmental experimentation on humans, and then you imply this into practice, develop it into a guideline, and the guideline will go into the community, tried by the community, and then you see the reflection. There are plenty of publications today. For example, this is one of the translational studies published in the journal of Pharmacology, using chimeric mice with humanized livers to predict human drug metabolism and drug-drug interactions. So how complicated, but eventually this basic science issue is being translated into clinical practice. Being aware of the importance of research in the process of training, it's not only education, it's not only didactics, but research is important. So we developed a new body in this country called the Egyptian Medical Research Council. This council is under construction. It is supposed to be involved in capacity building of researchers, of secretaries, of libraries, of journal knowledge database, and so on. Venues for the research. It's going to be involved with ethics, about ethics of clinical trials and ethics of animal experimentation, and all these kinds of things, considering religious aspects and ethics, other kinds. It will find resources for research and will provide financial support for researchers. Which researchers? Anywhere. It's not built for the universities. It is built for any researcher who wants to do any research in any peripheral hospital. He just writes what he wants to do, goes to the Medical Research Council, and gets support of how to do the research. They will help him with statistics, help him with money, help him with publication, and all that. So research is going to be something easy for everyone under the umbrella of the Egyptian Medical Research Council. So I hope I have shown you that it's no longer acceptable to split routine clinical practice from continuous learning and research. Learning in medical school is effective only until graduation, but CMEs must be carried out under the usual conditions of practice in the clinic. Training is a science in itself, which the trainers must learn and be audited for. Training must be nationally structured, monitored, tested, and enforced to ensure standardization of patient care and to ensure transparency and transferability. Clinical research is mandatory to build a thinking and critical mind of every clinician. Many fields are available for clinical research, including observational, interventional, and translational studies. And Egypt has already developed a master plan for ensuring these principles, and implementation has started over the past few years. The National Residency Training Program is due for March 1st this year. So according to this Chinese philosopher, who published his very famous saying in his book Tao Te Ching, many years BC, that a journey of 1,000 miles begins with a single step. Thank you very much for your attention.
Try this one.
For the sake of time, we'll move on to the second speaker. It's with great pleasure and honor that the Egyptian Society of Nephrology welcomes Professor Claudio Ponticelli to its annual meeting. Professor Ponticelli is Emeritus Professor of Nephrology in Milan, Italy. Actually, Professor Ponticelli is probably one of the very few nephrologists worldwide who has a treatment, not just a disease, but a treatment named after himself, the Ponticelli regimen for membranous nephropathy. And even more prestigious is that this treatment works. And therefore, it's with great pleasure and honor to welcome you in Egypt, Professor Ponticelli.
Thank you very much, Mr. Chairman. And let me also thank the organizing committee for giving me the opportunity to attend your National Congress. It's for me a special honor and a great pleasure to be here. Is this? Excuse me?
Professor Ponticelli's lecture is on the predictors of ESRD and recurrence of lupus activity after initiation of dialysis in patients with lupus nephritis.
Hi. Okay. Renal disease is a frequent and severe manifestation of systemic lupus erythematosus, and a number of factors can influence the prognosis of lupus nephritis. Some of these factors are unmodifiable factors such as gender, age, and ethnicity, but I rather prefer to focus on some potentially modifiable factors. The first of them is the delay in referring the patient to the nephrologist. In this retrospective study, patients were classified according to their GFR at the moment of renal biopsy, and they were subdivided into three groups: GFR more than 60 milliliters per minute, between 30 and 59 milliliters per minute, and less than 30 milliliters per minute. And after 10 years of follow-up, the probability of complete remission and patient survival without dialysis were highest in patients with GFR more than 60 milliliters per minute and lowest in those with GFR less than 30 milliliters per minute. So the first message is that a delayed referral can have deleterious consequences on the long-term outcome. And this has been also confirmed by a Swedish study that showed that those patients who started treatment after more than 6 months of nephritic symptoms had the highest relative risk of developing end-stage renal disease. Another prognostic indicator can be the renal biopsy. As you know, today, 6 different classes of lupus nephritis are recognized. Among them, the most important for the nephrologist are class 3, 4, and 5. Class 3 means that less than 50% of glomeruli are affected by proliferative lesions that can be active, chronic, or active plus chronic, as in the second figure. Class 4 means that more than 50% of glomeruli are affected by proliferative lesions that can be active or chronic, but also segmental or global. And class 5 of membranous nephritis is subdivided into pure class 5 and class 5 plus proliferative lesions. Usually, diffuse proliferative lesions, class 4, are considered the most severe form. And this has been in some way confirmed by our experience. Nonetheless, I should like to point out that even patients with proliferative glomerulonephritis could have a relatively good prognosis in the long term. I'm sorry, you can see the assist, but up to 20 years, almost 80% of patients were still alive with kidney functioning. Activity and chronicity indices have been proposed by the NIH many years ago. Activity index results from the sum of 4 parameters, which are scored between 0 and 3+, with the exception of fibrinoid necrosis and cellular crescents, who have to be doubled in scoring. A chronicity index results from 4 parameters, also scored between 0 and 3+. These activity and chronicity indices have been criticized by some investigators because they couldn't find any correlation between the score of these indices and the outcome of their patients. Of much importance, both activity and chronicity index may depend by the subjectivity of the investigator. In our experience, we tried to find the value of these indices. And looking at the baseline renal biopsy, those patients who doubled their serum creatinine had more or less the same activity index in comparison with patients who maintain a stable renal function. Instead, patients with renal insufficiency had more frequently a chronicity index more than 5 in comparison with patients maintaining stable renal function. Of some interest, in control renal biopsy, those patients who develop renal insufficiency had a significantly higher activity and chronicity index in comparison with patients who maintained stable renal function. Therefore, we can say that active lesions at baseline have a weak prognostic power, but this is due to the fact that they can be reversible if patients are adequately treated. And therefore, it is important to know whether the activity index is low or elevated, since this can be a good indicator to the treatment that can be aggressive or relatively less aggressive. Low scores of chronicity index seem not to influence renal outcome, but high scores are associated with poor outcome. And with few exceptions, a high score of chronicity index is a good indicator of poor prognosis in the long term and probably to the usefulness of treatment. However, let me point out that there is not any absolute cutoff either for activity or chronicity index. An important clinical parameter is remission. In this retrospective study, those patients who entered complete remission had an excellent 10-year and renal survival rate, while patients who didn't have any response had a poor outcome, both in terms of patient survival and renal survival. These data were confirmed by a number of other investigators, and some of them pointed out that the rate of loss of proteinuria at 6 months may help in predicting which patients will attain a complete remission. Renal flares is also important. Dr. Moroni in our group defined 2 types of renal flares: nephritic flares, meaning a rapid increase in plasma creatinine of at least 30% over the baseline associated with nephritic sediment, and proteinuric flares, arbitrarily defined by an increase in proteinuria of at least 2 grams per day.